prednisone do the same thing? Does prednisone do the same thing, like a high-dose prednisone, or the betamethasone acts differently and is required nonetheless?
I believe that the betamethasone is the best option for the fetal lung development and works differently than the prednisone, but maybe an MFM might be able to give a better answer.
Yeah, so I can answer that one for you, Dr. Leiser. The prednisone does not cross the placenta. It's oxidized into cortisone or into its oxide by 11-beta hydroxysteroid dehydrogenase 1, if you care about the enzyme involved. The reason we use betamethasone for fetal lung maturity and not a non-fluorinated steroid is because we need that steroid to get through the placenta. So we could replace the prednisone with the betamethasone for the treatment of the maternal cancer. But if you're giving prednisone for the cancer, you need to give betamethasone to mature the fetus.
So, resident friends, if somebody asks you why betamethasone and dexamethasone are the only two steroids that cross the placenta, why is that? Is there something biochemically different about those two? Do you remember organic chemistry 1,000 million years ago?
I honestly don't remember.
I mean, it's fine if you don't, but if somebody asks you, they're fluorinated. They're the only two fluorinated steroids.
Thank you.
Yeah. It might come up on a multiple choice test someday.
Raj, is there anything else that we missed here? Was there anything else you wanted to tell us that we didn't ask you?
I don't think so. I think this was an interesting case with managing delivery of the patient versus giving her chemo and having a discussion with the hematology oncology team every day. But I think the best care was provided for this patient.
All right, well, thank you, Faraj, as always, for an excellent job. It's only 1 or 2 minutes early, so I think it's okay for us to go ahead and start grand rounds. In just a minute, I'm going to ask Dr. Rosenfeld to introduce our grand round speaker. But in the meantime, we'll be taking attendance using the participants list of the Zoom at 8:10. If your name is displayed clearly, then we've got you. If you're displaying as a phone number or a computer name, please email or text your attendance to me or Michelle or to Beth or to Millie if you're a student. And also the CME will be distributed by the email system later on during the presentation. So with that, Dr. Rosenfeld, are you ready to introduce our speaker?
Yes, good morning, everyone. I am so excited to introduce Dr. Thornburg this morning. Dr. Thornburg is the James R. Wood Jr. Professor of OBGYN and Division Director of MFM at the University of Rochester Medical School, where she completed her residency and fellowship. She is board certified in maternal fetal medicine and complex family planning. Dr. Thornburg is an NIH-funded researcher who has won many teaching and leadership awards. She is passionate about the care of people with complex diseases in pregnancy, most notably focused on neurologic diseases in pregnancy. She has worked with several organizations, including ACOG, the New York State Department of Health, the Perinatal Quality Foundation, and SMFM to help birthing people access the care they need to have a safe and healthy reproductive life, including labor and delivery. Please join me in extending a warm welcome to Dr. Thornburg.
Thank you so much for having me. I'm very excited to be here, even if it's virtual. I know for us, virtual grand rounds have really improved our attendance, and I hope you guys are seeing the same. I'm going to talk about neurodisease in pregnancy, and of course, this is the talk where it's, well, maybe it's not always preeclampsia, but we are going to talk about a bunch of neurodiseases. I could talk about neurodiseases all day, so I've kind of focused this talk on neuroemergencies. I could also talk about neurochronic disease. I could talk about neuromuscular disease, but we're gonna stick with kind of neuroemergencies just because I think that it's something that obstetricians as a general group are going to encounter. So I do not have any big disclosures. I do have a digital software company that is an education software, and I do have a book on neurologic diseases in pregnancy. If you're a student on this talk, I can assure you it is not an Oprah book, and I have not seen royalties from that one. So this is the hill that I'm going to die on, which is that untreated or undertreated neurologic disease is not good for anyone, the patient or their baby, and that no patient should die or be denied the standard of care in their pregnancy simply because they are pregnant. And there is no medication, therapy, or imaging that is as dangerous to the dyad when we think about the long-term consequences of having a parent with untreated or undertreated neurovascular disease, especially, as a parent with untreated or undertreated disease. I'm gonna make my email stop thinking. So in general, my guiding principle is that pregnant people should get the same evaluation and imaging as non-pregnant people. If you get, this is, a slide just illustrating the point with a lion and a baby cub, that if you get half the imaging and get half the imaging, and you get the incorrect answer because you only got half the imaging because you were somehow protecting the pregnant person, you could end up down a very wrong path compared to if you get the real imaging that you need. Okay, so when I mean the same therapy, I mean thrombolytics, I mean surgery, I mean neurosurgery. I do not think you should delay emergency care for fetal evaluation. You should try to do these simultaneously if possible, and then immediate and aggressive care should be the goal for all neurologic disease. I'm going to give you a lot of details on acute management of neurologic disease, but I'm going to also give you some summary algorithms as I go through. These were all published by me and Dr. Wesley last year. They're all available on the ACOG expert series. And so I want you to kind of load those in the back of your van and have those for later. And I can send that PDF if anybody wants it. So we're going to kind of take a systems-based approach to neuroemergencies, because neuroemergencies typically present similarly in pregnant and non-pregnant people. And most neurologic diseases, kind of all roads lead to Rome, they eventually present with headache, paralysis, seizure, altered consciousness, meningeal signs, or focal neurodeficits. And one of these 6 things is going to really unite basically all neuro events. So if you have a patient who presents with one of these 4 things, headache, focal weakness, seizure, or altered mental status, this is a Venn diagram that I like because, obviously I made it, so I like it, but I like it because it helps me when I'm thinking about an overlap between altered mental status and headache, for example, what things are in that overlap. When I think about seizure and altered mental status, what things are in that overlap. And it gives me kind of at least a broad target, right? Because something like intracranial hypertension is unlikely to present with a seizure. It's much more likely to present with a headache. So it kind of gives me at least a ballpark of where I'm thinking when I've got these 4 signs and when I've got them overlapping. Now, remember that stroke can just do anything it wants because it can affect any part of the brain. And I've used a lot of abbreviations and I've given them out over here. Okay. So this is the one question that I encourage everyone to take away from this. It doesn't matter whether it's neuro or cardiac or ALL care or whatever it is. If they were not pregnant, what would you do for this disease event symptom, right? Because I think as OBGYNs, one of the most important things we can do is not cede the moral high ground to inaction. So what I mean by that is that doing nothing is not necessarily safer for the pregnant person or their baby. And we have a lot of consultants. I happen to be married to an internal medicine doctor who, have this very healthy fear of pregnancy for whatever reason. And they think that if they do nothing, that will be the safest thing for a pregnant person or mother and baby. And it is just not true. So this is the question I ask every consultant. What would you do for, say, this horrific arrhythmia, VTAC, that's happening in this patient? Well, if she wasn't pregnant, we would shock her. Well, let's do that, right? Because dead people have very poor perfusion of the placenta. So let's keep everyone alive because that will improve things. And my second question is, and joking on what you did this morning, but this is actually my second question. Assume I've thought of preeclampsia. If I'm calling you, I want you to help me see if there's any other things that I can blame this on. Okay, so let's do headaches first. I'm going to do it by case just so that we kind of get an idea of what we're kind of thinking about. So this is a 32-year-old G2P0. She's at 32 weeks. She calls ahead with a severe headache. Started yesterday and nothing's helping. So what kind of questions do we want to ask? And if I was there in person, I would run up and down the aisles and find all the students and make them answer me. But these are the things that we all learned in med school. Is this a new headache? Is she a person who has recurrent migraine? Is this a chronic or recurring headache? Is this a sudden headache? Those keys, the thunderclap. Is this a sudden severity? And the keys we want to watch for are markedly different in character or manifestation, increasing frequency or severity, and if it's accompanied by neurosymptoms. Those would be things that would not point to just a simple headache. So while I agree with the speakers this morning that you always have to think of preeclampsia, one of the dangers of being an obstetrician is that we always think of preeclampsia. So if it's kind of like the worst club call of all time. I say headache, you say preeclampsia, right? Because we all think preeclampsia the second we see headache. And there's a lot of other things in the brain and in the body that can cause headache. And in fact, if you go to Creasy and Resnick, which is the big MFM textbook, I was doing this actually just a couple nights ago. If you put in headache in the search bar, it will come up for everything, including like hepatic capsule rupture can present with headache. Like everything can present with headache. So our differential is really going to have, the chronic headache. We're going to think about tension headaches, migraine headaches, sinusitis, pseudotumor. For new and acute headaches after 20 weeks, we're always going to have to put preeclampsia on the differential. But the sudden severe headache, especially with neuroscience, don't forget about subarachnoid hemorrhage, which is, can happen for aneurysms or AVMs. It can also happen as a secondary consequence of preeclampsia. Don't forget about central venous thrombosis, especially in early pregnancy in a patient who's dehydrated or struggling with hyperemesis, meningitis, and then mass lesions. So if the patient comes back for the same thing, please expand your differential. So migraine and headache are the most common neurologic complaints of pregnancy, and they are the most untreated. Migraines actually have a very high risk for hypertensive disorders of pregnancy, preterm birth, low birth weights, and stroke. So just because a patient has a history of migraine doesn't mean you can't be like, oh, well, this is a migraine, it's not preeclampsia. Actually, these patients are at increased risk for that. And you want to think about, if you have patients in your office who have chronic migraines, preventative non-medication therapies, things like hydration, sleep therapy, or sleep hygiene, behavioral modification, screen time limits, blue light, all of those things. This is my too long didn't read answer to what to treat pregnant people with headaches with. And in general, everything that's on the right at the top is my safe go-to list. And really, you can see that the only thing that's on the bottom is ergotamines. In the middle, we have NSAIDs, which you can use in the first and early second trimester. My go-to is less than 20 weeks. Furoset is a great headache treatment in moderation, but can have rebound headaches. So medication overuse headache, which is a very common neuro diagnosis. So be careful with it. Opioids, really in general, not recommended. Steroids, pros and cons to steroids, including hyperglycemia and LGA. And then, most of actually our triptans and our nausea meds, mag oxide, actually melatonin as well, are all helpful on this end. This little symbol that looks like, I was trying to make it look like boobs, it's the infinity symbol. That means that it's okay in breastfeeding. So just keeping in mind that combined oral contraceptives are an independent risk for ischemic stroke, and especially among patients who have migraine. While the absolute risk is small, the risk is related to the dose of ethinyl-estradiol. Progesterones don't increase this risk. Always, if you have more questions and you have things you want answered, remember that mother to baby will chat with any attending or resident or even patient who wants to talk about medications in pregnancy. And the lactation study line here, which is where Ruth Lawrence did her care, will chat or talk to any doctor as well. Okay, but this patient does have preeclampsia. She's 32 weeks. She has blood pressures 160 on 110, 3+ proteinuria. Her platelets are 55, so she's got HELP syndrome. we admit her for our favorite drugs, magnesium and betamethasone. We give her some oxycodone for this headache because it's terrible. We start her induction and her headache continues to worsen. And it starts getting complicated. Her headache becomes a little bit more than just a headache. She seems altered, muddled. She's not making sense. She starts vomiting. Do we want to do anything different, or are we going to blame the magnesium? Well, I think we should probably do something a little different, because people who have preeclampsia, eclampsia can go on to have both hemorrhagic and ischemic strokes. So unfortunately, preeclampsia is a risk factor for both vasospasm and vasoconstriction, leading to ischemic stroke, as well as hemorrhage in the brain, leading to a hemorrhagic stroke. So how are we going to image them? It always comes down to, you want a CT or do you want an MRI? CT scans, if your hospital is like my hospital, you can't actually leave the emergency room without passing through the CT scanner, is my understanding. I'm joking. But it is first line, it is rapidly available. It is very, very good for subarachnoid hemorrhage. You get your answer right away. It has, it is the standard of care for early stroke evaluation. It does utilize a small amount of radiation, but the amount in the head is very, very small, rarely less than 2.5 rads, and fetal shielding, gets this way lower. MRI does not have radiation, but MRI takes a lot more time and effort to get. If you think somebody is having an acute stroke, the answer is CT scan, whatever you can get the fastest. So there's the potential for delay in evaluating a patient with an MRI. It does give better imaging of some structures and conditions. So if you're looking at a patient who you want to evaluate the course of their MS, MRI is the way to go. But if you have somebody with an acute stroke, it's CT scan. And contrast in MRI is really something we don't recommend in pregnancy if you can get the answer any other way. Okay, so if you ever get in a fight with radiology about wanting to do imaging in pregnancy, which may just be me, but if that's something that's ever happened to you, the ACOG committee opinion is very, very clear on this. And it says that most diagnostic procedures are associated with little or any fetal risk and should not be withheld from pregnant people simply because of pregnancy. Now, if you take an ACOG committee opinion down to a radiologist, my guess is they're not going to be super familiar with them. So you can point out the American College of Radiology guideline, which they should be familiar with. And in that guideline, they specifically call out that examinations of the head and neck, you do not need a pregnancy test or pregnancy status to proceed with examinations, any examination of the head and neck. So even though your patient is pregnant, remind them that they don't actually even need to know that when you're talking about examinations of the head and neck, because the risk to the fetus is so low. Okay. When you get a CT scan, this is what you're looking for. You're looking for what I call the angry starfish. So you're looking for blood in all of these little fissures. If you see that, you have subarachnoid blood. It doesn't tell you where it's coming from, but it tells you have blood in those fissures, and that's what's causing your headache and potentially your seizure and your altered consciousness. If you think that there could be infection, or you want to confirm blood, you want to do an LP. Now, you definitely want a CT scan first, right? Because unless you want to learn how to treat hernia, you want to make sure that the patient doesn't have elevated intracranial pressure before you do an LP. And then if you think there's a mass lesion or, an ischemic stroke that needs more evaluation, you're going to do an MRI. Okay, so subarachnoid hemorrhage is actually responsible for a big chunk of maternal death. You cannot distinguish the etiology based on symptoms. The etiology of anything that gives blood in the brain is sudden severe headache, so that thunderclap headache that we all learned about in med school, nausea, vomiting, and meningeal signs, and the inability to bend your head or move your head with that headache. And so if you have any of these three, together, especially, your first thought should be, is there bleeding in the head? Secondary symptoms are going to include focal deficits, altered consciousness, seizures, hypertension. Again, hypertension is both a cause and an effect of hemorrhage in the brain. But really, if you see those three things together, think subarachnoid hemorrhage from whatever etiology. The treatment is ABCs, just like anybody else who's having an acute life-threatening event. Blood pressure reduction, getting the cerebral edema down. Mannitol is safe in pregnancy, although it can cause some oligo. Again, that's a very secondary consideration to saving the maternal brain. Seizure control, and then fetal monitoring only if you plan to act on it and there's a concern for fetal hemodynamic instability. So in general, people who are having strokes or subarachnoid hemorrhages will be hemodynamically stable. They usually do not have major hemodynamic alterations. It can come from a wide variety of reasons: ruptured cerebral aneurysms, vascular malformations, arterial malformations, preeclampsia, eclampsia. Uncontrolled hypertension and preeclampsia is a much higher risk than we once thought. And this is related to systolic, not diastolic blood pressure, so the peak blood pressure, as well as delays in treatment. So this is why SMI and Safe Motherhood and all these things, and CCQC from California, why everybody harps on this, wanting to treat blood pressures acutely and to acutely manage blood pressure in pregnancy, because it really does increase your hemorrhage risk. We think about AVMs as one of the reasons why people do get subarachnoid hemorrhage. There's about a 2% annual rupture rate in the population, and only about 18 per 100,000 people have these. But if you have one, your risk of rupturing in pregnancy is actually much, much higher. Why is that? Your volume goes up, your stroke volume goes up, so you're putting a lot more pressure on that AVM. And so the risk of rupture in the reproductive years is actually 7 times the population risk. Up to 25% of subarachnoid hemorrhage in pregnancy is due to AVM, and maternal mortality can be as high as 30 to 40%. You can get bleeding both subarachnoid, and you can also get it parenchymal, so you can get a secondary hemorrhagic stroke. And if you know about these prior to pregnancy, think about treating them, because they often can be treated endovascularly and very easily. If they're more than 5 centimeters, they really do tend to enlarge. And these tend to rupture earlier than aneurysms. So AVMs tend to rupture in my least favorite time frame, that 20 to 24 weeks, with a second peak postpartum. When you're thinking about treating an AVM, think about neurosurgery. If you need to treat them, avoid hypotension during that surgery if the patient is pregnant. Babies do not like hypotension very much. Endovascular approaches have much lower complications. But again, people who are candidates for endovascular approaches probably have different AVMs than people who need an open cranium. Delivery mode after repair in pregnancy, most people are going to recommend a C-section. Passive descent and operative delivery may be reasonable. Stable and unruptured, you're going to think vaginal delivery, and then surgically repaired before pregnancy vaginal delivery. So altered mental status often happens as a pre-seed or a post-seed, so you can't use that as just a evaluation by itself. But if you do get a patient with altered mental status, you want to think about what happened before, and you want to see if you can narrow down the onset and to help narrow your differential. So when you have somebody with altered mental status, it's all of the neuro stuff, but it's also all of the metabolic stuff. So drugs and intoxication can alter your mental status, even things like hypoxia. All causes of seizure, all causes of intracranial hemorrhage, preeclampsia, eclampsia can often make people have altered mental status and muddled. All of us have had the experience of having talked to a patient for what we think is hours during their hospital admission for preeclampsia, and you see them back in the office and they have no memory of all the things you talked about and the risks of the preeclampsia and the future risks and all those things, because they really aren't making good connections during that time. Hemorrhagic stroke and then ischemic stroke as well. Thrombotic and ischemic stroke is a very rare diagnosis in pregnancy, but it is the second leading cause of death in women in general and accounts for about 12% of maternal death. Mortality is as high as 25% in patients who have a ischemic stroke in pregnancy, but hemorrhagic is actually more deadly than ischemic. And postpartum is actually your highest risk time. So that 50% of your pregnancy-associated strokes are going to happen in that first 10 days postpartum, and then the other 50% in the late second and third trimester. Hypertensive disorders of pregnancy increase the risk of having a stroke in that period about 7-fold. However, the majority of these, the vast majority of these, occur without hypertensive disorders of pregnancy. Other risk factors are things that we see all the time: cesarean, infection, thrombophilias, AVMs or aneurysms, which can have a secondary ischemic stroke, cardiac disease or cardiomyopathy, and people throw small clots. And then high order parity actually increases your risk of stroke, even without anything else. CT remains the mainstay of imaging for people with stroke. And again, your initial care is exactly what you do for anyone who's having an acute problem: ABC, and then stabilization of blood sugar. The brain can only use sugar, it cannot use ketones. So you want to make sure that you're keeping a good supply of sugar for that brain. You want to maintain adequate blood pressure to assure cerebral perfusion. Excuse me. And then if they do have intracranial hypertension, you want to treat with mannitol or dexamethasone. And there's really minimal risk to the fetus during a thrombotic or ischemic stroke as long as there's no vascular instability. Okay, I'm putting up the treatment of stroke in severe hypertension and I'm doing it across a couple different things because I just want to point out that acute stroke, intracranial hemorrhage, subarachnoid hemorrhage, and hypertensive encephalopathy, which are all hypertensive diseases or strokes of the brain, are all of the preferred first-line agents are nicardipine. So if you have a patient who's having any brain symptoms associated with hypertension, the first line is nicardipine because it has less of a selective effect on the brain and it has a much better profile as far as avoiding vasospasm in the brain. The other thing I want to point out is that in acute ischemic stroke, so if you're not perfusing your brain, this is the one time where obstetricians need to sit on our hands and take a beat from our neurosurgery friends and not treat to safe motherhood goals. Because we don't treat ischemic stroke until those blood pressures are more than 220 on 120, which is also where I start to have chest pain. And if they've gotten thrombolytics, a little bit lower than that, but even 185 on 110 does make your obstetrician heart go pitter pat. And the reason is because we want to make sure we're perfusing that remaining brain and keeping it from having secondary watershed. So just remembering that, you know, anybody with an ischemic stroke, we're going to treat at a much higher, and then just keeping that in mind, aortic dissection, also something that can cause stroke-like symptoms. You want to rapidly reduce those. And then intracranial hemorrhages, you need to balance the risk of perfusion and rebleeding. And why is all this? Why am I harping on this? Because if the blood pressure is too low or the blood pressure is too high, you increase your risk of both death and dependency. So this means, this is the dependency side. Sorry, that color is hard to see. But the point is that if your blood pressure is too low or too high, you end up with an increased risk of the two things we don't want to have happen to this person, which is lifetime of care or dying. And if you keep your blood pressure in that sweet spot, which is actually a little bit higher than we like to see blood pressures, 160, then you really do end up with a better outcome. So thrombolytics are a question that we do get when we have patients with acute stroke and pregnancy. There is no RTC data on this. Obviously, you're not going to randomize people with strokes to usual care or not. Both RTPA and urokinase have been described, neither across the placenta, but they can cause intrauterine hematoma, miscarriages, intracranial hemorrhage, and death. Thrombectomy is also described. The best data we have for RTPA comes from the VTE data. And the VTE data suggests that pregnant people have the same risk of bleeding and complication rates as non-pregnant people when receiving that therapy in pregnancy. Obviously, the risks and benefits of this therapy depend on gestational age, size of the stroke, and prognosis for that pregnant person without therapy. As one of my professors, when I was a med student, used to say to me, even the most well-formed fetus does very, very poorly in the dying mother. So please give the therapies you need. This is my algorithm for managing stroke and pregnancy. And it basically divides it into hemorrhagic events and ischemic events. I'm going to give you this mnemonic, and I'm going to talk about it again later. The A, B, C, D, E, F, Gs. So it's ABCs, and don't ever forget glucose. The brain can only use glucose. So A, B, C, D, E, F, G for all of your brain patients. If you have a hemorrhagic event, it goes down reversing coagulopathies and blood pressure control. And if you have ischemics, the same. I have not called out everything there is to know about stroke and the care. Basically, it's let neurosurgery and neurology do what neurosurgery and neurology do after you ask them the question of what they would normally do if the patient wasn't pregnant, and they do that. And these are the things that are a little bit different in pregnancy that you're going to want to keep an eye on to help them get best care for your patient. So this is my next section. What do all these people have in common? Little Wayne, Theodore Roosevelt. This is a heterogeneous group, let's just go with. All of these people have had a seizure, and they all have a known seizure disorder. And most of them you don't know. Seizure disorder is the single most common neurologic condition in the population. Okay, so We have a 25-year-old G3P2. She's 28 weeks. She walks into triage. She called ahead because she's having this gross vaginal discharge that she wants checked out. The nurse puts her in a room and she sees it. Well, crap, right? The day just went to crap. So now you got to deal with a 28-week seizure in your triage. And if you're like me, you're like, is it 5:02? Can I hand this to someone else? Just kidding. So you're going to go in and deal with that. So what is our number one question to ask that the boyfriend, the family member, who's ever in there with her? That number one question is going to be, does this patient have a seizure disorder, right? Now, you almost don't have to ask this question if the boyfriend or family member is continuing to text and looks very nonplussed. This patient has a seizure disorder, right? They've seen this before. They're not worried about it. If the patient is texting during their seizure, they have a pseudo-seizure disorder. Okay, so what are we going to do next? Are we going to give magnesium? Are we going to do a code blue? Are we going to turn the patient on her side and give her oxygen? Are we going to take her to the OR for an emergency cesarean? Are we going to put on the fetal monitor? What's our next best choice? And obviously, it's harder when I'm not in person for you guys to vote, so I'm just going to give you the answer. And the answer is we're going to put the patient on her side and we're going to put O2 by mask. And why is that? Well, the magnesium, while important for a patient who's having a seizure when you're not sure if it's preeclampsia or not, is actually for the next seizure. It will not stop the current seizure. It's only going to help prevent the next one. Most eclamptic seizures are self-limited. And so, you know, getting IM magnesium into somebody's butt cheeks, if you haven't ever done it, by the time you get it up, the seizure will be over. So focus on taking care of the pregnant person. The magnesium's for the next seizure. Please don't call a code blue. You're going to get all sorts of people you don't know and aren't going to be helpful. That can be great if the seizure continues, but your initial response needs to be putting them on the side. Do not do a C-section in the middle of a seizure. Please take care of the pregnant person. And the fetal monitoring is going to look terrible. So this is what you want to do. Your A, B, C's, right? So your seizure patients get a seizing ABC. So that's how you remember it. So it's airway, breathing, benzos, and blood. So you want to check all the things that can cause seizure in the blood if you can. Blood sugars at top one, electrolyte, the tox screen. Benzos if you get beyond 5 minutes. Circulation and disability once they wake up, looking for a neuro exam. Try not to look at the baby. This is like DKA or anybody else who's having an acute sepsis. You know, the strip is not going to be good. This is my dog. He was very shamed by his hat on Christmas. So this is the algorithm for managing seizure. You can see that it goes from 0 to 60 minutes. If someone is 60 minutes into a status, you better believe that I'm hoping somebody else is there besides me, because that is not my job. I want you guys to all be able to manage the first 0 to 5 minutes. So we're going to focus on that. So again, stabilizing the patient, the A, B, 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 C's. And if you get to 5 minutes, you want to think about adding a benzo to your life. And this is my mnemonic. So in IV lorazepam, it's 0.1 milligram per kilogram up to a max of 4. Who's going to remember that? It's 4 at 4 minutes. So at 4 minutes, you call for 4 milligrams, and almost everybody in the world is going to be at a 4 milligram dose who's pregnant. So 4 at 4. Just like with your ACLS arrest, we talk about delivery by 5. Same thing with a seizure. You want to give a benzo at 5 minutes, so call for 4 milligrams at 4 minutes. Okay, so our first question, do they have a seizure disorder? And then our second question as an MFM or an obstetrician has to be, could this be preeclampsia? If it's not 1 or 2, then we need to go down all the other things, meningeal irritation from anything that irritates the brain, metabolic disturbances, including hypoglycemia, drug or alcohol withdrawal, and then neurodegenerative and autoimmune diseases can cause seizure too. This is my seizure algorithm that I think is a little bit easier to understand than the one that goes to 60 minutes. So this is your ABCs, and don't ever forget glucose. If it's at 4 minutes, do your benzos. The seizure continues, move to the algorithm for status. If it resolves, then you go down the, could this be eclampsia or is this not an eclampsia seizure? And so you kind of have to do the 2 workups, which is, I think it's eclampsia. We're going down the eclampsia thing. If it's not eclampsia, then we're going down the imaging stroke protocol side. Okay, what's going to happen to the fetus? 80% will have a deceleration. The majority of these will have tachycardia after they recover and minimal variability. You have been warned. This is going to look scary. It will typically last, that deceleration, 6 minutes. So remember, I told you an eclamptic seizure typically only lasts 2 minutes. That decel is going to last longer than the seizure. And so when you put that baby on the monitor after the seizure's over, just expect that you're going to have a decel for some period of time. And the onset after the seizure is typically 3 minutes after the seizure. Now, again, this makes physiologic sense, right? The oxygen takes a minute to wear down, all of those things. Also, you probably gave a benzo or you started magnesium. And so now you've taken away any reserve that's going on in that fetal heart rate variability. So keep in mind, you're going to have a decel and it may actually be delayed after the onset. So when you put the baby on, it might be low. Magnesium versus other antileptics. I get this question a lot. Magnesium is the mainstay of therapy. It is more effective than anything else that we've used. It is the drug of choice, and retreatment after 24 hours of therapy is rarely indicated. We give benzos and phenytoin only in the context of anti-epileptic treatment or when magnesium is contraindicated or unavailable. So patients with myasthenia, typically, we don't like to give magnesium to people with severe hypoglycemia, again, a rare diagnosis, but possible. People who have moderate to severe renal failure, you can either bolus and do no continuous, or you can use a different agent. And patients who have ongoing cardiac ischemia, heart block, or myocarditis are not going to tolerate magnesium well. People with epilepsy represent about 0.5 of the population, 5% of the population, which is actually very high. It is our most common chronic neurological condition. There is a markedly increased risk of seizures in people with epilepsy while they're pregnant. We don't exactly know why. It's likely multifactorial. The reason probably has to do with a bunch of things, including change in susceptibility when you're pregnant. You're more prone to seizure. You have more changes in the binding protein levels within your body. You have changes in your volume of distribution. You have absorption and hepatic clearances of AEDs change. So anti-epileptic drugs is what AEDs are. And so it is important to be watching levels in these patients, especially lamictal, which is highly, highly affected by that estrogen pathway and that binding pathway, and is one that's going to need adjustment up during pregnancy and then rapid adjustment down afterwards. So, and our death rate of people with epilepsy in pregnancy is rising, primarily due to poor control. And we've all had this experience. I have a bad seizure disorder, but I stopped my meds when I got pregnant because I didn't want to hurt the baby. Well, an uncontrolled seizure is also really bad for the baby. This is my list of safe to less safe with AEDs. None of them is perfectly safe. In general, the valproic acids are less favorites for pregnancy, while our more safe groups include things like lamictal and gabapentin. And, it's kind of a mixed bag. I tried to give you some ups and downs as to what's going to happen to them during pregnancy and some compatibility with breastfeeding. But in general, the thing that controls the seizure is the best thing, right? So if the only thing that controls their seizures is phenobarb, then you have to counsel on it and think about it, but you really should be thinking about whether taking them off is the right answer. Monotherapy is better than multi-therapy, even if it's a more dangerous medication. So lowest dose, least teratogenic, best monotherapy. So again, if you can give a small dose of valproic acid versus 4 other seizure meds that we don't really know how to interact with each other, it may be better to go with the smaller dose of a known issue medication. And then really work to avoid triggers, especially in postpartum people. So postpartum people with epilepsy have a lot of hormone fluctuations, just like everybody postpartum. Well, estrogen and progesterone are highly neuroactive, and protein binding and liver glucuronidation both return to normal after pregnancy. So this is going to shift their AED levels. Sleep deprivation is very common postpartum, especially if you take a baby home with you. Weight changes, water shifts, especially if you're breastfeeding. And epilepsy is a highly stigmatized disease. So these patients have very low rates of social support and social engagement. They have a much higher rate of unplanned pregnancy or paternal non-involvement than the general population. and they have higher rates of postpartum mood disorders. So this is a group that you want to see back in the office. You don't just want to send them out and see them back at 6 weeks. So you're sending a patient with epilepsy home. This is for our intern friends. What do you want to put in the discharge instruction? Follow up for levels in 1 to 2 weeks. Don't use changing tables in your home. Change the baby on the floor. Taper plan for their anti-epileptics. Do not use a chest carrier like a Bjorn or a Swaddler. Use a stroller in your home instead of carrying the baby, and use a car seat in your home when going up and down stairs. Does everybody send patients home with these instructions who have epilepsy? I'll say most of us do not, but best care is actually to do all of those things because the seizure threshold is so wonky in that immediate postpartum period. You're tired, you're not sleeping well, your levels are all over the map as your weights are changing. They do recommend that you do all infant care on the floor, that you never carry the baby, and that you never bathe the baby alone if you are a person with epilepsy until your levels have been stabilized and you've gone a period of weeks without any seizure issues. You want to encourage a second adult in the home for 4 to 6 weeks. This is the printout you can use. And then, ideally, this is a group of people who pumping and allowing for one feed so that they can get a longer stretch of sleep will really improve their risk of not having a seizure. All right, are you ready for a little bit more, or is your brains filled up? We'll do just a few more things. All right, so this is my brain mnemonic. So B's, A, B, C, D, E, F, G is your B's. It's your basic ACL care, your blood, and your blood sugar. This is your approach to all neuro diseases in pregnancy. R, review the events with the family and attempt to narrow the differential. Talk to them about what happened before. Oh, right beforehand, she fell and hit her head on a metal plate. Okay, that's going to change what we're going to work up here. Ask the question, what would we do if the pregnant person was not pregnant, and avoid the knee-jerk reaction of we can't because of pregnancy. Well, we can do a lot of things in pregnancy. I'm here to help you do them in the safest way possible. But the answer of we just can't is generally not right. Imaging, do any imaging you need for the neurodisease involved. Use contrast in MRIs only if you need it, but do not substitute inadequate or limited imaging due to potential risks of fetal exposure, because we don't know the risk of not knowing, of treating the wrong thing and ending up down the wrong path. And then N, neurology and neurosurgery, involve these teams early and support them in their care, engage in a discussion of pregnancy physiology and how this is going to change things, and then advocate for early and aggressive imaging. And this is a great place where we can support our neurology and neurosurgery colleagues, right? Reminding them that airways in pregnant people tend to be smaller and more difficult. And, maybe our pH shouldn't be 6-9 because baby's really not going to love that. So things that are more difficult for them to remember. All right, so in summary, I was trying to leave lots of time for conversation. Neurologic disease in pregnancy should be managed similarly to non-pregnant adults. Imaging and evaluation should be completed promptly. CT scans of the head are safe and rapidly available, and you do want to ask the question. So I've given you a bunch of neuro algorithms and neuro things that you can use when you see a patient with neuro concerns. But in general, your approach should be that time is brain. Pregnancy complications may increase, but in general, neurologic stabilization is always going to come before fetal intervention. Follow-up and aftercare for those with ongoing physical and neurological challenges is going to be harder than actually treating the disease in front of you. And so I left lots of time so we can talk about cases or things that you have questions about.
Thank you, Dr. Thornburg. Thank you so much. Are there any questions? I see that Dr. Rosenfeld has her hand up. Dr. Rosenfeld, you're muted.
Sorry about that. Someday we'll all get it right. But thank you so much for a wonderful presentation. I really enjoyed your talks at the Critical Care Conference and today as well. One case that I have come across recently that was a little bit difficult to suss out is the case of pseudo seizures. Could you talk a little bit about what your approach is for those patients and any words of wisdom that you have for that?
Those are really tough, right? And they have a new name now, which I can never remember. They keep renaming them so that like the stigma disappears and then the new name will get stigmatized and then we'll have to rename it again. It's like acute neurologic, I don't know, I can't remember what it is. But anyway, pseudo seizures are in general not dangerous, right? Because people still are protecting their own airway. They are basically the brain saying, I'm too overwhelmed by whatever's happening in the world and I need to do a hard reset, right? So one thing to remember with them, which I think was really hard for me to get my head around, but maybe the rest of you are less biased than me, is that the patient isn't doing it voluntarily. It's not that the patient is faking a seizure. It's that the brain chemistry is such that they're so overwhelmed by whatever emotional trigger is happening that their brain's answer is to shut down and space out for a minute. And so it is not a voluntary reaction. I think we have to be thoughtful that this is not the patient really trying to piss us off and not engage in care. It's that they have such bad trauma in their life that this is how they're physically manifesting it. I don't have any words of wisdom other than most of the time, these patients really benefit from slow introduction of things, from understanding what their triggers are, from involving neuropsych and cognitive behavioral therapy if you can, because that's really what they need, right? Is to figure out why it is that they can't handle the engagement and whatever the event is that triggers them. But it's really challenging.
I see that, oh yeah, go ahead, Dr. Rosenfeld.
Oh, I have another question, but I'll let Dr. Siegel go first.
Dr. Siegel?
Yes, hi, great presentation. I wonder if you could talk to us. You said about 6 minutes, the after a seizure, the heart rate goes down. How do you prepare for delivery at that point? Because usually at 6 minutes, we're running the patient to the operating room. And that's what I do usually when I hit the number 6. So I guess, can you take us through how you make decisions about when to actually do the delivery in a post-ictal phase, or maybe even in an active seizure?
I think this is absolutely one of those things that there's no right answer on. It kind of depends on how quickly the patient is stabilizing and how bad the decel is. I mean, I know this is like, I'm not giving you a hard and fast number, but in general, I would put kiddo on the monitor. And yes, at 5 to 6 minutes, I would be thinking about whether we should be moving to the operating room, just like you. And even if you move to the operating room, right? And then once you get back there, you recheck and see if it's come back up. That is one thing I'm going to be doing. The other thing is if it's very, very early gestational age, I'll watch a little bit longer than if it's a full-term patient for obvious reasons. And I still would defer that C-section until the airway's stabilized and the patient is well oxygenated and all those things. So even if at 5 minutes you go to the back because you're continuing to have a very long decel and you're concerned that it's not going to return. And again, these patients who have a bad seizure could also have an abruption or something else, right? It doesn't mean they can't have two things, especially if it's an eclamptic seizure. So, but I still would, even when I got back there, if there's a decel, you wouldn't obviously want to do a C-section on a patient with an unsecured airway, right? So I would move towards those things as I was watching. But yeah, you definitely would be thinking about where your resources were and thinking about whether you want to do your next part of your evaluation in the operating room. But it's hard to watch.
And just what do you give in terms of phenytoin? I know you can't push it, right? You can't push it. So
Yeah,
what do
you
you
have
do?
to, that's one that you don't use for acute seizure. That's more of, you can do a phenytoin drip or you can do oral phenytoin. You can also do, people do Keppra as well. But nothing works as well as magnesium if you have the opportunity to use magnesium, if the diseases in question will allow you to do it. One thing I didn't talk about today, which I think is a common thing that we don't think about, but should be on everybody's radar, is after delivery, thinking about epidural abscess and epidural hematoma. And again, these are super, super rare diagnoses, but if you have somebody who in the postpartum period is having neuro symptoms that are either unilateral or are out of proportion to just kind of the normal post-delivery, I'm just tired kind of stuff, and especially if they're focal, one-sided or those kind of things, imaging of the spine in that postpartum period is really important because disabilities longer than 6 to 12 hours are associated with no return of function or even death if it's an abscess. So that's an occasion where we should be waking up all of our colleagues. It's another neuro emergency, again, really rare, but something to just kind of keep in your back pocket when you're rounding in the postpartum unit. Do you use magnesium in your renal patients? Or do you switch drugs?
Yeah, we usually give boluses.
Yeah.
Is that what you do as well?
I mean, we do boluses and levels and then rebolus if we need to, is what we try to do. In general, that's what we do too.
Yeah, that's exactly what we do.
But in general, that's what we do.
Yeah.
And like in a dialysis patient, it actually is almost easier than in the patient who has just renal disease because you give the bolus and you're done, right? It just doesn't go anywhere, as opposed to the renal patient who's clearing some but not all, and so you have to kind of follow it a little more closely. It can get pretty challenging for us. So that's a group that's difficult. One thing that I'm just curious about, it isn't actually like, I don't have a dog in this fight. So your patients with gestational hypertension, do you start them on medications before you make the or even preeclampsia without severe features? Do you start blood pressure meds before you make the diagnosis of preeclampsia with severe features?
We generally don't. This is what I do and most of my partners. We don't start them on medication unless they've required pushes of medication.
And that means their severe features, right?
Yeah. So we usually don't try to temporize any disease process. I think that the MFMU has a study that they're
doing it right now.
Yeah, I don't know if you're involved in it.
Not, but I think this is an area where we've seen a lot of like creep. People have taken the CHAP and like they've started treating gestational hypertension and preeclampsia without severe features. And then I think you mask the severe features and then you struggle with when to deliver. So I anecdotally think that we're seeing a few more seizures than we used to because I think that we hide that diagnosis a little bit from ourselves in people that we start medications on when we shouldn't be. So we don't actually know. Maybe it'll be beneficial, but we don't actually have that data yet. So yeah, we try not to treat them either. But same as you, we get a lot of transfers, and we'll get patients who get transferred in.
Yeah. I'm curious what you do in terms of postpartum magnesium if someone's already received magnesium.
We don't remag typically. Do you remag?
Not unless they have neurologic symptoms.
So if they've already had magnesium, but they have new neurosymptoms, you would remag?
In some cases.
I mean, I might remag a seizure, but generally not. I might remag a seizure. I take that back. I might, but I don't think I would remag anyone else really. I don't remag. I might readmit, I might rewatch, I might do those other things, but I typically don't remag. And you know, there is no data. You get into the law of diminishing returns, right? Like people just don't know. And then even when you get the postpartum diagnosis of preeclampsia with severe features, we don't know that the number needed to treat is the same as people who are, you know, in the immediate events, but we do MEG people with postpartum diagnoses if they have not been previously received magnesium.
Sorry, I'm not raising my hand, but I have a complimentary question. I'm Emily Daggett. I'm the second year fellow, MFM fellow. Do you MAG people who come in remote from delivery, over 24 hours from delivery, with new severe preeclampsia who haven't been MAG'd before and no neurologic features?
So we often start magnesium during our evaluation when we're trying to figure out whether we're gonna, like, we think they're preeclampsia with severe features. We put them on magnesium while we're kind of sorting out whether they're gonna go to antepartum or whether they're gonna need delivery, I guess is kind of what I'm saying.
Sorry, I mean postpartum.
Postpartum. So once they're postpartum, we MAG everyone with severe features.
Even if they are starting to have severe features greater than 24 hours after delivery. Okay. So even if someone comes in like a week postpartum with new postpartum severe preeclampsia. Okay, great. Thank you.
Admit and we remag. So again, like on day 3, if you rule in for preeclampsia, we extend your admission and do 24 hours of magnesium.
Thank
And
you.
we send everybody home with blood pressure, cuff monitoring, and rapid follow-up in the office. And then we have an actual preeclampsia co-clinic with cardiology for patients with preeclampsia with severe features to be followed by cardiology postpartum to be kind of aggressive with their blood pressure care and their neurovascular care.
That's great.
Yeah, it's been very helpful. Because it's hard to get people into their primary. I don't know if you have this problem, but we
Very much so.
can't find a primary, right? Like mine can never retire. I told her she has to work till I die. So,
Thank you, Dr. Thornburg. This is a great talk.
happy to talk again. Happy to do a different part of neuro if you guys are ever interested. Thank you so much for inviting me. I'm also happy to stay on for a few minutes if people have questions or other things they want to ask me.
Thank you so much.
No problem. All right, I ended by 9. I know that was the goal, so you guys can all get to the office. So have a great afternoon.
Thank you so much. All right, so we'll end it here.